it's really hard to know whether that surgery for that patient will improve someone's pain, because you ultimately have several different types of pain.
Yeah.
And there are the two common types that we see in our clinic are the nociceptive pain. So it's like, I use the analogy, like if you've got a hammer and it's hitting your finger, well, you stop the pain by just removing the hammer.
Yeah.
And so in the context of endometriosis, it's kind of, well, you stop the pain by removing the endometriosis. The challenge is the other type of pain that we see people getting is pain that feels like the hammer's hitting when the hammer's gone, because the hammer's been hitting the finger for so long that the nerves are just in a pattern of firing. So people detect pain, but there's no actual stimulus there to be causing that pain.
In today's video, I had the pleasure of interviewing Dr. Martin Hirsch. Dr. Martin Hirsch is a consultant gynecologist and endometriosis specialist at Oxford's John Radcliffe Hospital in the United Kingdom. He works as a full-time gynecological surgeon specializing in excision surgery for people with endometriosis. Alongside this, he is an elected senior council member on the British Society for Gynecological Endoscopy, helping to shape future endometriosis care nationally. Martin was awarded a postgraduate medical doctorate research degree from Queen's Mary University of London in the area of endometriosis and has received national recognition awards from NHS Improvement, the British Society of Gynecological Endoscopy, and Health Education England. In our video today, we talked about some exciting updates in the European practice guidelines involving endometriosis. We also spoke about strategies for managing endometriomas, how patients might approach well-meaning but uninformed medical professionals about suspected endo, and about fertility and endometriosis and some important considerations. If you haven't already, please like this video, share it with a friend, and hit that subscribe button, and happy watching. So I am joined today by one of my favorite people in the endometriosis space, Dr. Martin Hirsch. We've done at least one other collaboration together in the past, and I'm so grateful for your time because I know you're a busy guy. Could we just start off with a brief intro, Dr. Hirsch? Could you tell us a little bit about who you are and what makes you a great person to talk to about endometriosis?
Of course, thank you so much for the kind introduction. So my name is Martin Hirsch. I'm a consultant gynecologist and endometriosis specialist working in Oxford, England. I have been interested in endometriosis since medical school back in the early noughties. Crikey, that's a long time ago. And inspired by some fantastic mentors that were passionate about the specialty back when we knew even less than we know now. I'm pleased to say things have progressed a little bit since then, but we still have a long way to go in the field, which is what makes me so motivated and passionate to be involved in both clinical practice and research within the field of endometriosis. And, I've done a thesis that was 3 years of my life and about 60,000 words that is readily accessible and freely available online if anyone wants to look at my thesis. It's at QMUL, which was the university that I studied at in London, looking at diagnostic and therapeutic challenges for patients with endometriosis, freely available. Don't expect people to read all of it, but if you want to access some bits, everyone's welcome to. And I've kind of got 30 or 40 publications in the field of endometriosis. I work closely with different research groups locally in Oxford, as well as groups in London. I'm a kind of an associate editor at a journal that specializes in endometriosis called Facts, Views and Visions, that's run by the European Society for Gynae Endoscopy. I sit on the board for the British Society for Gynaecological Endoscopy, which is where I am today. I'm up in Leeds at their conference, which is great so far. Looking forward to the rest of it. I'm also passionate about thoracic endometriosis and trying to centralize the care for patients with thoracic endometriosis, which I really do think will follow a very similar journey to what rectovaginal or bowel endometriosis has gone on in the past 15 years. And so, yeah, that's a kind of, in a nutshell, a summary of me.
Professional history. That's amazing. We are so happy to have you working in the endometriosis space. And are your publications, are they all in slightly different areas within the endometriosis space? Or are they all kind of diagnostic or dabbling in a little bit of something different?
Yeah, good question. So a lot of kind of epidemiological, so it looks at kind of bringing lots of studies together to find some kind of wider answers in the form of systematic reviews. And I've done some that are as far afield as looking at how accurate Google searches are for endometriosis.
Interesting.
All the way to looking at the variation in quality of the different guidelines that we have available to guide our clinical practice. And also another systematic review looking at the accuracy of one of the previously most common diagnostic markers for endometriosis, which was CA125. That's no longer used, but was a really interesting and kind of wide-ranging thesis that I put together. And more recently, I've been looking at kind of larger scale data analyses from the British Society for Gynae Endoscopy database that has I think the single largest collection of surgical data for endometriosis, with I think over 20,000 patient episodes on their database, looking to evaluate different trends and themes in improvements in pain based on the type of surgical procedure or adopted.
Fascinating. Really helpful information for us to have in the endometriosis space, it sounds like. That's great.
I hope so. I'm not a basic scientist, so I don't work in a laboratory looking at cells under a microscope. Sure. That's not my forte, but I'm more interested in kind of pulling together bigger studies and bigger collections of data to answer some wider questions. But each their own. I mean, there are lots of people that do fantastic things that I work very closely with that do laboratory-based stuff, but that's not my area of expertise.
Yeah. It's okay. That's okay. Speaking of large bodies of data, you've recently been posting a little bit on your socials on what's the short form? ESHRE? ESHRE, the European Society of Human...
We commonly say ESHRE.
ESHRE, okay. Yeah, so that stands for European Society of Human Reproduction and Embryology. Is that right?
That's right.
Okay.
An important fun fact from my systematic review that pulled together all the guidelines, that was the highest quality guideline of all the guidelines out there.
Amazing. Okay. So maybe you could tell us a little bit about your favorite information that's come out of these new guidelines, maybe top 1, 2, or 3 things that are quite a bit different. And before we hit the record button today, I mentioned some of the ones that I had to read through when I was looking through the guidelines that were quite refreshing to hear, new forms of diagnoses being recognized as valid and accurate for deep infiltrating endometriosis. So yeah, if you could maybe give us like top 1, 2, or 3 guidelines that have changed, or what you have found the most refreshing of the new guidelines.
Sure. I mean, a little bit about the backdrop of me kind of starting that short series that I do hope and plan to continue is that there's a lot of misinformation online. There's a lot of people making recommendations or saying things that they've heard from other people that can snowball. And snowballing information can sometimes be dangerous, and people can head down a route of believing something that lots of people are saying is true, but may not necessarily be born out of any robust clinical data. And guidelines, they are just that. They are guidance, but they're guidance on the best quality information we have available to us at any one point. And if you think about the hierarchy of data, which tells us, what's the most valuable data and what's the least valuable data, guidelines and systematic reviews sit right at the top. And personal opinion, or my own personal opinion, sits right at the bottom. So I think it's just hopefully a small refresher to people, to patients with endometriosis, to guide them towards reliable sources of information they can trust, and that are based on data and hopefully the highest quality data that we have available to us. What I'm really pleased about in the ESHRE guidelines is the inclusion of a few new sections, and those sections look at extrapelvic endometriosis, including thoracic endometriosis, and also pediatric and adolescent endometriosis, because those two entities have always existed. People have always had thoracic endometriosis, and there have always been adolescents with endometriosis, but it just wasn't covered in the guidelines previously. And I'm really pleased that the guidelines, under the stewardship of my close colleague Christian Becker, have taken on those areas to review them in this recent guideline, and provide clinicians with guidance, with advice about how best to perhaps manage the cases that aren't always that common, and can be challenging. And yeah, they've kind of enabled us or signpost us in the right direction. And particularly with areas of diagnosis as well, there have been advances to include ultrasound as being an accurate and reliable source to include endometriosis when it is detected on ultrasound with an advanced ultrasound person, or with someone that has high quality skill in performing ultrasound. Now, I think it's important to note that ultrasound can't fully exclude all aspects of endometriosis, particularly not superficial or peritoneal endometriosis. But if you're having a scan performed by an expert in ultrasound and they detect endometriosis, that is likely to be accurate enough to confirm a diagnosis, which I think is an important change, because it perhaps enables people to take strength and positivity in the diagnosis without necessarily having to undergo a surgical procedure, because each surgical procedure carries with it risks that can put your health backwards, as well as hopefully take your health forwards. But those risks can take your health backwards if they do occur. So if you are someone that would ever want to consider hormonal treatments for endometriosis, but you perhaps wouldn't want to consider them without a diagnosis, then this next step in the guideline iteration is really important, because it hopefully gives them confidence to say, yes, I have endometriosis based on this ultrasound by an expert, and therefore I would feel comfortable in using this hormone treatment or that hormonal treatment. And so, yeah, they're kind of perhaps the three areas that I'm really excited that have been included.
It's very refreshing to hear. You're absolutely right. People have always had thoracic endometriosis. Young women have always had endometriosis. And so, yeah, it sounds like extremely important inclusions in these guidelines. I wanted to ask, maybe this is a bit of a curveball and you totally don't have to answer this question, but you made a comment about, some people putting out information that maybe isn't always true. Is there something specific you're referring to there?
No, not at all.
No.
I just think that, some people feel kind of passionate about the treatment that they've had.
Yeah.
And we're all aware that on social media, it isn't necessarily the most accurate
Sure.
form of information that takes hold and goes viral. It is sometimes the person that says it the best or has the most influence that enables a concept or a belief to propagate. And I guess I hope this series enables people to access and listen to the opinion of kind of very esteemed academics and researchers that have come together to put this guideline together. I'm not trying to persuade everyone and anyone to believe these concepts, but
Yeah.
from my personal opinion, as both a clinician and scientist, I feel that is the most robust data that we have available to us to guide our decision making as clinicians.
Yeah, agreed. You and one other surgeon, endo specialist, or two like surgeons, doctors, people working in the medical field when it comes to endometriosis that I really, really trust. But I've also, I felt myself becoming really conflicted, because then another person who's also a surgeon working in this space will tell me, no, you can't diagnose endometriosis through an ultrasound. And then that just kind of gets me really confused, when I believe, based off of the data that I've seen, that you absolutely can. But it's important to identify that this is, somebody who's trained in this. It's advanced ultrasound. It's not just through like a regular, ultrasound that you might be using to scan your bladder or something like that. So, even when it comes to within the industry, I think there's still a lot of, I don't know, maybe difference of opinion there, right?
Yeah, I completely agree. And ultrasound is one of those really challenging tools in that the accuracy of the test is totally dependent on the person that's holding the
Yeah.
scan probe. And so having confidence and faith in the person that's performing that scan is paramount.
Yeah.
And understanding their skill level beforehand is essential.
Okay.
And trusted sources of information that I can signpost people to are Matthew Leonardi, a world leader in ultrasound, Joel Naftalin, and Elizabeth Bean, who are all kind of present on Instagram, trying to promote really positive messages about the role of ultrasound.
Yeah, and I did an interview also with Dr. Matthew Leonardi, and we sat down and we talked at length about ultrasound. So anybody watching who's interested in that can also have a peek at that interview. Okay, so I wanted to change the topic here a little bit. Endometriomas, I find, are one of the most complex aspects of endometriosis. And I wanted to get your professional opinion on what is the best way to manage recurring endometriomas. I know a lot of people are interested in the answer to this question.
Yeah, it's a really hard answer.
Yeah.
And as soon as you asked that, I had kind of like flow pathways in my head, just kind of like clicking off, because it's so hard, and I could probably sit here for a really long time to talk through the different kind of eventualities. But I would completely agree with you. It is perhaps the most complex area of endometriosis, because it's not just a surgical procedure, it's operating on a reproductive organ that has huge consequences to patients if the operation doesn't go well, or if there's recurrence of disease. So just a bit of backdrop, endometriomas are ovarian cysts where you get an endometriosis lining within that cyst. And there are generally 3 different approaches to surgically treating that cyst. One is draining it with or without burning of the lining of the womb. And that maybe has less detrimental effect on the reserve of the ovary, but has a greater likelihood of recurrence. It doesn't also have as beneficial effect on pregnancy rates or pain relief. You then have cyst removal, where you open the ovary up and then peel the cyst off the ovary, and that has benefits to reducing pain, improving the chances of natural conception, but reducing the reserve of the ovary such that if that person needed fertility treatment in the future, their success rate may be lower because the reserve of the ovary may be lower. And then there's a third technique that not as many people use, but is an emerging technique, and that's called alcohol sclerotherapy, which is where a small catheter is placed inside the cyst. The cyst is then the contents are removed, and then alcohol is inserted and left for about 10 to 15 minutes. And it provides a burning to the inside of the cyst such that recurrence rates are believed to be low. It doesn't provide as much depth of penetration to damage the ovary itself. So the reduction in the ovarian reserve isn't believed to be as profound. So from my understanding of the data, it doesn't drop your ovarian reserve as much. Your recurrence rates are relatively low and perhaps comparable to removal of the cyst. I'm not entirely sure about the data on how well it reduces pain or whether it improves someone's ability to fall pregnant naturally, but that may just be my ignorance, and I'm not aware of the data.
It's relatively new though, isn't it? Because I've seen that popping up in I have these like automated Google emails that come to me on topics related to endometriosis, and I just recently started seeing that pop up in the studies.
Yeah, well, I mean, people have been performing it, I don't know, 5 to 10 years, but it's
really?
like with any new technique, it takes a long time for people to become familiar with it and then to adopt it within their practice. I know Dr. Shaheen Khazali has some wonderful videos on his Instagram page about how the procedure is performed, if anyone's interested. It's not a procedure we've adopted yet in our center, but it is something we really want to for those patients where it'd be valuable. But again, it is just about having to travel to another center to learn how it's done, then coming back to your center, filing all the paperwork and applications that are required to trial a new technique, monitor it, perform the audit, ensure the governance is in place to make sure that patient safety is paramount, and before then rolling it out and implementing it more widely within your hospital.
Yeah, interesting. And what about hormone therapies? Are you getting any success with Visane or birth control or other progestin-only meds?
Yeah, so hormone therapies form a big pillar of treatment for the patients that I see. And so I tend to run through 4 different treatment options with almost every patient I see, because I really want to promote patient choice in the treatment options, because certainly in the UK, there is a huge movement against historic as well as current medical misogyny that doesn't necessarily offer women the choice of the treatments that they perhaps can have available to them. So I feel it incumbent on myself to offer all the treatments that are available, and allow the patient that's sat in front of me to make the choice. And those 4 treatments tend to be non-hormonal options. So that could be painkillers, that could be acupuncture, heat therapy, cold therapy, yoga, diet changes, TENS machines, physiotherapy or physical therapy, that have some benefits towards improving pain, but maybe don't address the disease at its source. But for some people that want to avoid surgery and hormones, they can be really good options. There are then first-line hormonal options, like you say, that can include combined hormonal contraceptives, progesterone-only contraceptives, or non-contraceptive hormones like Visane, that I think we call Zalkia or Dynagest here in the UK, as well as norethisterone or Provera. And then there are the hormone blockers. So they might be like the gonadotropin releasing hormone agonists or antagonists. People might recognize the names of Zoladex, Lupron, Prostap, Decapeptyl, Ryeco, Linzagalix, Relugolix, those kind of medicines that aim to block receptors within the brain that stop the ovaries being fed by hormones that stimulate them, and therefore the ovaries don't respond, they don't stimulate, they don't produce a cycle, and people have an induced temporary but reversible medical menopause. And then the 4th pillar is those surgical treatments, and those surgical treatments are always very nuanced to the individual that sat in front of me, and they generally are either conservative, so preserving fertility, or more radical.
Mm-hmm. So I'm gauging that there isn't one best way. It's really patient dependent, context dependent for managing the endometriomas.
For endometriomas, it totally depends on the situation that a patient is in. And so for everyone with an endometrioma, the minimum that I would want to do is a detailed scan to assess the size and the shape of that endometrioma, ensure there are no concerning characteristics. And then an AMH or anti-Müllerian hormone. So that assesses the overall function of the ovary and enables a more informed discussion about whether surgery is likely to severely reduce their ovarian reserve, such that if in the future they needed fertility treatment, that would be, that may not even be successful. They may not get a response. So without that information, I can't provide appropriate counseling to the patient in front of me. And I don't feel that the patient can make the right choice without all the information that can be available to them. So certainly there are lots of options, but another area that we hadn't discussed with endometrioma is fertility preservation, which is a huge area for perhaps patients where their ovarian reserve isn't particularly high, but their pain levels are such that no other treatment has been successful for them. They're not in a position to try for a family at that point, but they know they want one at a later date. And for that cohort, we might talk about fertility preservation before undergoing surgical treatment that may negatively impact their ovarian reserve.
Does the AMH, if it's a low AMH, does that give you information about how involved the endometrioma may be in terms of their ovarian health and ovarian function?
Well, the AMH tells us that their overall reserve of their ovaries, which is like the total number of follicles, has dropped to a low level. And while it's not a hormone in its own right, it is a level that it is reasonably stable. Hormonal treatments can reduce it. Surgical treatments tend to have a reverse tick effect. So you start at your baseline level of AMH. The surgery then drops it quite rapidly before it then recovers to perhaps about halfway or kind of 2/3 of the way from where it was. So the AMH is just a guide to tell us. It won't tell us necessarily whether someone will be able to fall pregnant naturally or not, but it'd be a guide to say what their response will be like, or perhaps what their success will be like if they needed fertility treatment in the future. Yeah. And as someone that's not a fertility specialist, I don't do IVF, I don't do IUIs, and I don't do ovarian stimulation. I work very closely with fertility specialists that I refer to directly for patients that do want to consider fertility preservation.
Okay. It's a bit of a direction change, but as a doctor, as a surgeon working in this space, what type of data, information do you think is most valuable for a patient to bring to a doctor who suspects they may have endometriosis? Unfortunately, I mean, I think it's getting better now with doctors like yourself, with Dr. Matthew Leonardi. You know, women are being heard. Their symptoms are being taken a little bit more seriously, but unfortunately it's still happening, right? Where we're being brushed off or gaslit or just being handed a birth control pill. So as a doctor, as a surgeon, is there certain information that if a patient brings to you, you just wouldn't be able to ignore? Or maybe it would help encourage other doctors who are maybe still doing that, maybe still just offering the birth control, to maybe take a deeper look?
Yeah, so I guess I'd go to any health consultation as informed as you can. And we spoke earlier about the dangers of misinformation, but do your best to try and access high quality, reliable sources of information beforehand. So for patients in the UK, I always tell them, you know, if you think you have endometriosis, read the UK-based guidelines on how we in the UK should be managing endometriosis, and that's the NICE guidelines. And that provides a really detailed description of what family doctors or general practitioners should be doing if someone goes to them with signs and symptoms of endometriosis. And that includes referral to a hospital if a patient has persistent signs or symptoms of endometriosis. You know, and certainly within the UK, patients aren't mandated to have hormonal therapy. Hormonal therapy is an option, certainly for people to try, but you know, a referral for consideration of further investigations or surgery is recommended where hormonal therapy is not effective. So it's not worked for a patient. It's not indicated. Maybe a patient has had a blood clot and they can no longer take any hormonal therapies, or maybe they've had a cancer. Unfortunately, there's a hormone-sensitive cancer, so they can't take hormones. Or it's not acceptable to a patient. And there are a lot of people where external or synthetic hormones aren't acceptable to them. And I fully respect that. And in those situations, you know, we are recommended as healthcare professionals in the United Kingdom to refer people on for further investigations and other tailored medical or surgical treatment options in a hospital setting.
Yeah, I like that. I always encourage people to, like, how much more insightful and hard to ignore would it be if you came in with just information about your own body, like how many painkillers you take a day, or, you know, in the high pain phases of your cycle, how many are you taking? Is the minimum safe recommended amount of ibuprofen, for example, something that's not even touching your pain? And having that data to present to the doctor, I feel like that's so much more powerful too, right? Just to kind of paint the picture of how severe the symptoms are.
Yeah, totally. I think I did a post on this on Instagram, kind of going to your GP saying, these are my ideas, these are my concerns, these are my expectations, based on the following. I get pain with my periods that requires X amount of painkillers. And my feeling is that this may represent endometriosis. I'm concerned that this may be having an impact on my fertility. And I've reviewed all the treatment options, and I don't think I'd be willing to accept anything other than further investigations with or without surgery, for example. Please, can you refer me on to a specialist? For some patients, they may want to try hormonal contraception. They may want birth control. They may want to prevent pregnancy. And if that is the case, then it is an accepted treatment approach. But for those patients that want to understand more, say they want to know whether they've got severe endometriosis. Unfortunately, in the UK, access to that kind of level of diagnostics is only within a hospital setting.
Yeah. I like that little script you gave us there. I'm gonna recommend that everybody takes that script and takes it to the doctor if they suspect they have endo. Okay.
Yeah. But that's a challenge, right? Because, I'm trying to put myself in the shoes of someone that's 25 with severe period pain. They're not in a position to try for pregnancy. I'd want to know what's going on.
Totally.
I might be happy having a treatment that stops me falling pregnant if I didn't want to fall pregnant, and may help with some of my pain, but I'd still want to know what's going on. And that's one of the major barriers that we face in the UK, is that we don't have accessible, high-quality diagnostic tests. So almost everyone that comes to my clinic will have had an ultrasound in the community, and unfortunately, the diagnostic accuracy of those ultrasounds in the community here in the UK is low. And they cannot exclude deep endometriosis, and they definitely won't be able to exclude superficial endometriosis. So it's only if someone that's in the community has an ovarian endometrioma, which already, like we said, is bad news, will they be able to get a diagnosis reasonably promptly, because those community-based scans will be able to detect them. So it's for the other two cohorts of patients with deep and superficial endometriosis, it's often a really long wait for accessing a diagnosis.
Yeah, I've heard that that's the case in the UK, although I don't think it's too much better in this part of the world, Canada and the US. I'm bouncing a little bit back towards the fertility realm. I know you mentioned you're not much of a fertility specialist, in that you don't perform, assisted reproductive technology, stimulations, and that sort of thing. So if you don't feel, confident responding to this question, that's totally fine. But I do get a lot of questions when I do Q&As, or if I've done interviews with other surgeons or endo specialists, on the appropriate timing. So if somebody did want to pursue IVF, let's say, to grow their family, what would you say? And I imagine there's probably a lot of nuance here into, the response to this question, but is it more appropriate to do excision first, then IVF, or IVF first, then excision? I've heard different responses to these questions, and I wanted to gauge kind of your thoughts on that.
Yeah, good question. So based on the ESHRE guidelines, my understanding is there's no discernible benefit from having surgery prior to IVF, unless it is that your ovaries are not accessible for an egg collection, for example, or you have a blocked and swollen fallopian tube that can negatively impact your success with IVF. And those two situations aren't all that common. So my understanding is that surgery prior to IVF will not increase your success rates. If anything, it may reduce your success rates, because you, one, have a risk of complication. Say you had an infection or a big abscess in your pelvis following surgery. That can severely damage your fallopian tubes. Your fallopian tubes, if they weren't blocked and swollen before, can become blocked and swollen. And then you may need a further surgical procedure before being able to proceed with IVF. Because there aren't many IVF specialists that would go ahead with IVF if someone had a blocked and swollen tube, because they know that that's going to reduce their success rates by about 50%.
Wow.
And most IVF centers are performance and data driven. And so they want high success rates, because that enables them to potentially attract more new clients. So whenever, in summary, in short to your answer, I don't think there's a lot of data to support surgery before IVF unless the ovaries are not accessible or there are blocked and swollen tubes. But if someone has severe pain as well, there may be a role to offer surgery to improve someone's pain in the run-in to IVF. Now, importantly, I don't believe that IVF is associated with progress in the disease or deterioration in symptoms, and that's my recollection of the data. There are kind of hundreds and hundreds of those recommendations within the ESHRE guidelines, but my recollection is that the IVF doesn't deteriorate symptoms or disease.
Yeah, I agree with you. I'm sure that the data doesn't show that information. I mean, anecdotally, I'm connecting only with endometriosis patients, and it's not super common. It's not like every single person I connect with who's done an egg retrieval and gone through an IVF cycle reports that their endometriosis symptoms are far worse, but I do see a pattern just anecdotally in practice.
No, of course.
You know, it's a lot of medications that you would logically think would irritate endometriosis, right? Or cause.
Yeah.
I was wondering too, if this logically makes sense to you. Like, I see a lot of reduced ovarian hormone production after excision surgery, especially if the ovaries operated on. I wonder if that has implications for fertility as well, right? Like, if you've just come out of surgery and now you're going to go into a stimulation and your ovaries are just, you know, underperforming temporarily, at least for the next 3 to 4 months before they come back to life, I would imagine that would probably also affect the outcomes of those fertility treatments.
Yeah, massively. So like I said before, if you chop a cyst out of someone's ovary, that's going to reduce their ovarian reserve as measured by the AMH level.
Right.
The AMH level corresponds directly to how well those fertility medicines will be able to stimulate the ovaries and be able to develop follicles and grow eggs. So, unless the ovarian cyst is huge in size or like stopping anyone from being able to access any healthy ovarian tissue, it's not common that we see people going ahead with surgery for ovarian cysts ahead of IVF in our center.
Yeah.
So, I'd say to people, be informed, read the guidelines. They are ultimately just guidelines, but guidelines are the top of the pyramid of information, and a person's opinion is the bottom.
It's funny. I like the way you say that. That's really funny. Okay, I don't know if this is a super quick question. If it's not, we can bypass it and pull it out because I know we're running out of time here. But are there any scenarios in which excision surgery might leave somebody worse off with endometriosis than they were before? Or maybe ablation surgery or a mix of both. I don't know if I've complicated the question now.
Yeah, it's really tricky, and everyone is an individual, and everyone that I see and manage wants to know whether surgery is going to improve their pain. And, it's really hard to know whether that surgery for that patient will improve someone's pain, because you ultimately have several different types of pain.
Yeah.
And there are the two common types that we see in our clinic are the nociceptive pain. So it's like, I use the analogy, like if you've got a hammer and it's hitting your finger, well, you stop the pain by just removing the hammer.
Yeah.
And so in the context of endometriosis, it's kind of, well, you stop the pain by removing the endometriosis. The challenge is the other type of pain that we see people getting is pain that feels like the hammer's hitting when the hammer's gone, because the hammer's been hitting the finger for so long that the nerves are just in a pattern of firing. So people detect pain, but there's no actual stimulus there to be causing that pain. And that can occur in patients both with and without endometriosis. And that's called like centralized pain or nociplastic pain, or non-nociceptive pain. And that's really challenging to be able to differentiate in a clinic setting and a discussion. And perhaps those patients might commonly present with pain that's just kind of constant, with less fluctuations based on a hormone cycle, perhaps, or with pain that perhaps doesn't respond as well to any of those hormonal treatments or hormone blockers, or or pain that's present in people that have had pain for a very long time. Because like I said, that kind of centralized pain syndrome tends to occur after someone's experienced pain for quite a long time.
And is that the pattern?
Which is why we desperately need to reduce that time to diagnosis and enable people to access the treatments that they thoroughly deserve promptly.
Yeah, agreed. And that's a pattern you see commonly in practice. Somebody who's had chronic pain for 10, 20, 25 years, having a little bit more of that like centralized pain that isn't helped as much by excision.
Exactly. And so I would love to say that absolutely everyone I treat surgically has an improvement, but I'd be lying. I want everyone to improve with surgery, and I want to make sure that everyone feels fully informed when they go into a surgical treatment. But there are cases of mine, and there are cases of absolutely every surgeon, I can guarantee this, of people not having an improvement that they want to have following surgery. I think that a surgeon isn't telling you the truth when they can guarantee you that your pain will improve. Sure. You ultimately, as my opinion is that you want to see a doctor that's going to tell you the truth. And if that truth is difficult to hear, that's still important to hear it before you undergo a major surgical procedure that carries with it risks.
Yeah.
It's always my best intention to improve people's pain, but it's in some situations where that pain isn't as a consequence of an endometriosis, most commonly it persists, and it can persist.
Yeah, interesting. Okay, well, I am so grateful for your time. Thank you so much. I know that you have somewhere to be. Very insightful.
Thank you.
And I'm sure that our audience will very much enjoy our conversation today, our interview. So
no, not at all. Thank you so much for inviting me on, Cindy. And sorry that we haven't been able to get any of the previous dates together, but it's always great chatting.
I know you're doing wonderful things for our community, and I can't be mad at you for that. But I'm glad that I caught you today. I'm so grateful. I'm so grateful to you. Thank you so much for tuning into today's video. Drop us a comment if you found it helpful and hit that subscribe button, and we'll see you in the next video.